I'm Raymond Kellerman, Senior Environmental Services Technician at St. Dominic Medical Center in Baton Rouge, Louisiana. I've worked nights at St. Dominic for 17 years, cleaning operating rooms, sterilizing floors, handling biohazard disposal, managing chemical protocols that most people don't even know exist in a hospital setting. I hold Level 3 clearance for infectious disease containment areas. I've been through OSHA certification programs that would make your head spin. I know every corner, every closet, every hidden maintenance corridor in that 400,000 square foot facility. St. Dominic sits on the eastern edge of Baton Rouge, a massive complex of interconnected buildings that's been expanded 7 times since it opened in 1962. The main hospital tower rises 12 stories, but most people don't know about the 3 basement levels that house everything from the morgue to the industrial laundry facilities to the network of steam tunnels that keep the place running. As Senior Night Shift Environmental Services, I have master key access to all of it. I'd cleaned up every imaginable horror, post-surgical gore, infectious disease spills, decomposition cases that had gone undiscovered for days. After 17 years, I thought nothing could surprise me. I've seen everything you can imagine in hospital maintenance. I've mopped up more blood than a crime scene investigator. I've sanitized rooms where people took their last breaths. I've worked through flu pandemics, COVID surges, and a hepatitis outbreak that nearly shut down our surgical wing. I developed what my supervisor called professional detachment, the ability to walk into any situation, assess the cleaning and safety protocols needed, and execute without emotional reaction. But what I'm about to tell you is the one case that shattered every assumption I'd built over nearly 2 decades of hospital work, something that still makes me question everything I thought I understood about the building I work in every single night. It wasn't the gore, it wasn't the death. It was something that violated every principle of physical reality I'd come to rely on in my profession, something that made me realize there are aspects of what happens in hospitals that can't be explained by medical science or rational thought. What happened on the night of September 12th, 2024, on the 7th floor of St. Dominic Medical Center should have been impossible. What I witnessed in room 714 defied every law of physics, biology, and reason that governs hospital work. And the worst part? I wasn't the only one who saw it. I still walk those halls every night, but I'm not the same person I was before that shift. September 12th started as a completely routine Thursday night shift. I clocked in at 10:47 p.m., exactly as I had thousands of times before. Our night crew consisted of 6 environmental services techs covering different zones of the hospital. I had floors 6 through 8 of the main tower, which housed general medical surgical units. My usual route: start with the common areas, then handle any discharge rooms that needed terminal cleaning, respond to any immediate spill or contamination calls, and finish with routine maintenance of nursing stations and public spaces. The nursing supervisor who briefed me that night was Claire Deshotel, a 23-year veteran who I'd worked alongside for over a decade. She mentioned that 714 had a discharge scheduled for the morning and needed terminal cleaning, full sanitization protocol after the patient transfer. The previous occupant had been a 72-year-old woman named Dorothy Arsenault, who'd been admitted 9 days earlier for complications from diabetes and kidney failure. Standard case. She was being transferred to a long-term care facility at 8 a.m., so I had all night to get the room ready for the next patient. I remember Claire specifically saying, "Room's empty now. Patient's down in dialysis for her last treatment before transfer. Should be straightforward." I grabbed my cleaning cart at 11:15 p.m. and headed up to the 7th floor. St. Dominic's 7th floor is laid out in a rectangular loop, 42 patient rooms arranged around a central nursing station. Room 714 was on the east wing, 3rd door from the end of the corridor, a private room about 180 square feet with the standard hospital setup: adjustable bed, vitals monitoring equipment, IV poles, a small bathroom, a visitor's chair, and a window overlooking the employee parking lot. I used my master key to access the room at 11:22 p.m. I note the time specifically because I logged every room entry in my phone, a personal practice I'd developed for tracking my work efficiency. The room appeared exactly as expected. The bed was stripped down to the plastic mattress cover. The 4th pole stood in the corner. The bathroom door was open, revealing the standard toilet sink shower setup. The vitals monitor had been powered down, its screen blank. The whiteboard on the wall still had Dorothy A. written in blue marker under the patient name field, along with her care team information and dietary restrictions. I began with my standard protocol. First, I conducted a visual inspection for any biohazard materials, sharps, or items requiring special disposal. Nothing unusual, just the expected detritus of a 9-day hospital stay. Some papers on the bedside table, a half-empty water pitcher, the usual items. I started stripping the disposable items, bagging trash, removing the mattress cover for laundering. At 11:34 p.m., I was spraying down the mattress with hospital-grade disinfectant when I heard the bathroom door close. Not slam. Close. A soft, deliberate click of the latch catching. I stopped mid-spray and stared at the bathroom door, now fully shut. The door I had seen standing open 12 minutes earlier when I'd entered the room. The door I hadn't been anywhere near. Hospital doors don't close themselves. These weren't automatic doors. These were standard hinged doors with manual latches that required active force to close completely. Air pressure changes from the HVAC system could sometimes cause doors to drift, but they wouldn't latch on their own. The mechanism required the door to be pushed past a certain resistance point. I set down my spray bottle and approached the bathroom door slowly. "Maintenance," I called out, which was standard protocol if you thought someone might be in a space you were about to enter. "Environmental services." No response. I reached for the handle and pushed the door open. The bathroom was empty, completely empty. The small space, maybe 40 square feet, offered nowhere to hide. No shower curtain. Hospitals don't use them for infection control reasons. There was just a clear plastic barrier. No storage cabinets large enough for a person. Just toilet, sink, shower with the plastic guard, and about 3 feet of clear floor space. I stood there holding the door open, trying to logic through what had just happened. Could the door have been slightly ajar and finally settled close? Possible, but I'd specifically noted it standing fully open when I entered. Could air pressure from me opening the main room door have caused a delayed reaction? Theoretically possible, but I'd been in the room for 12 minutes. That didn't track. I returned to my cleaning, but I'd be lying if I said I wasn't unsettled. I left the bathroom door propped fully open with my cleaning cart and continued sanitizing the main room. At 11:51 p.m., I was disinfecting the IV pole when the vitals monitor turned on. The screen flickered to life with that distinctive electronic hum that medical equipment makes when it powers up. The display went through its startup sequence. Manufacturer logo, system check, then the main monitoring interface with flat lines where patient vital readings would normally appear. I stood there staring at the screen, disinfectant cloth still in my hand. The machine had been unplugged. I had specifically observed when I entered the room that the power cord was disconnected and wrapped around the monitor's base. Standard procedure when preparing equipment for a room changeover. I walked over to the monitor. The power cord was still wrapped around the base, the plug dangling 18 inches off the floor. The machine was running on battery power apparently, but that made no sense either. These monitors automatically powered down completely when disconnected from mains power to preserve battery life. They didn't just spontaneously turn on. I reached to power down the monitor manually when the screen changed. Patient data appeared: heart rate, blood pressure, respiratory rate, oxygen saturation, all displaying active readings. Numbers that were updating in real time: heart rate, 87 beats per minute, blood pressure, 134/78 respiratory rate, 16 breaths per minute, O2 saturation, 96%. The readings were stable, normal, the kind of readings you'd see from a resting patient in relatively good health. But there was no patient in the room. The monitor was displaying vital signs for someone who wasn't there. The sensors weren't connected to anything. They were coiled on their hooks on the side of the machine. No finger clip for O2 saturation, no blood pressure cuff, no chest leads for heart rate. The machine was generating patient data with no patient attached. That's not how medical equipment works. These monitors are sophisticated devices that measure actual physiological data from sensors. They don't hallucinate readings. They don't display information about patients who aren't connected. If there's no input from sensors, they show flat lines or error messages, not active vital signs. I did what any confused technician would do. I turned the machine off and on again. I held the power button until the screen went black, waited 10 seconds, then powered it back up. The monitor went through its startup sequence again, and within 30 seconds, the same vital signs reappeared. Different numbers this time, but still displaying active patient data. Heart rate 91, blood pressure 142/81. The numbers fluctuated slightly every few seconds, the way real vital signs do. I unplugged the battery backup and powered the unit down completely. The screen went dark. I stood there in the silent room, my heart rate probably matching whatever phantom readings that monitor had been displaying. Professional protocol said I should report a malfunctioning medical device immediately. Faulty equipment is a serious safety issue in a hospital, but something stopped me from calling it in right away. Maybe I wanted to finish the room first. Maybe I didn't want to sound crazy reporting that a monitor was displaying vital signs for a patient who didn't exist. I returned to my cleaning routine, moving faster now, wanting to finish and get out of room 714. I sanitized every surface according to protocol: bed rails, bedside table, windowsill, light switches, door handles. I mopped the floor with quaternary ammonium disinfectant, working from the far corner toward the door. Standard terminal cleaning procedure. At 12:17 a.m., I was finishing the final floor mopping when I heard breathing. Not my breathing, someone else's breathing. Slow, regular, slightly labored. The kind of breathing you hear from elderly patients, especially those with fluid in their lungs or compromised respiratory systems. The sound was coming from the bed. I turned slowly, mop still in my hands, and looked at the empty bed, the stripped mattress, the bare rails, and I heard that breathing, clear as anything, coming from exactly where a patient's head would rest on the pillow that wasn't there. The breathing continued. Inhale, 2 seconds. Exhale, 3 seconds. Inhale, exhale. Rhythmic and real and absolutely impossible. Hello. My voice came out quieter than I intended. Is someone there? The breathing stopped. The silence that followed was worse than the breathing had been. I stood frozen in the doorway, mop in hand, staring at that empty bed. 30 seconds passed. A minute. Nothing. Just the ambient hum of the hospital HVAC system and the distant sounds of the nursing station down the hall. I stepped backward out of the room, pulling my cleaning cart with me, and closed the door. My hands were shaking. In 17 years, I'd never left a room without completing the terminal cleaning. But I was done. I was finished with room 714. I found Claire at the nursing station and told her the room had a malfunctioning vitals monitor that needed biomedical engineering to check out before I could complete the cleaning. She thanked me and made a note. I moved on to other rooms on the floor, trying to focus on routine tasks, trying to convince myself that exhaustion or stress had made me imagine things that had rational explanations. I finished my other assignments by 2:30 a.m. and was heading toward the elevators when I passed room 714 again. The door was closed, exactly as I'd left it, but I could see light underneath the door. The room lights were on. I'd turned off every light in that room. I was certain of it. Lights off is part of the final checklist for terminal cleaning, but now warm light was clearly visible in the gap between the door and the floor. I should have walked away. I should have called security or nursing or someone else to check it out. Instead, I used my master key and opened the door. The room lights were on, all of them. The overhead fluorescence, the reading light over the bed, the bathroom light. And sitting in the visitor's chair beside the window was an elderly woman. She was small, maybe 5'2", with thin white hair and deeply lined skin. She wore a faded blue hospital gown. Her hands were folded in her lap. She was staring out the window at the dark parking lot below. "Ma'am," I managed to say, "you shouldn't be in here. This room is being cleaned." She didn't turn, didn't acknowledge me at all, just kept staring out that window. I took a step into the room. "Ma'am, are you a patient? Do you need help getting back to your room?" Nothing. No response. No movement except the slight rise and fall of her shoulders as she breathed. I took another step forward, and as I moved closer, I could see her reflection in the window glass. Her face, her features, and I realized I recognized her from the patient photos that are kept in the medical records, photos taken at admission for identification purposes. It was Dorothy Arsenault, the patient who was supposed to be in dialysis, the patient whose room I was cleaning. But that made no sense. Claire had specifically told me the patient was down in dialysis and the room was empty. And even if there had been some miscommunication, even if Dorothy had returned early from treatment, she wouldn't be sitting alone in a darkened room in a chair. She'd be in bed with her vitals being monitored. She was a high acuity patient with kidney failure. She wouldn't be mobile and sitting unattended. "Mrs. Arsenault," I said, "are you okay? Do you need me to call your nurse?" The woman turned to look at me. Her eyes met mine. And in that moment, I saw something in her expression that made my blood freeze. Not confusion, not distress, just a calm, knowing look that suggested she understood exactly what was happening, and I didn't. She opened her mouth as if to speak, and then she was gone. Not gone as in she got up and left. Gone as in she vanished. One moment she was sitting in that chair, solid and real and looking directly at me. The next moment the chair was empty. No fade, no blur, no movement. She simply ceased to exist in the space she'd been occupying. I stumbled backward out of the room and collided with someone in the hallway. It was Claire, coming to check on the room. "Raymond, you okay?" she asked, steadying me. "You look like you've seen a ghost." The unintentional accuracy of that statement almost made me laugh hysterically. Instead, I grabbed her arm and pulled her toward the room. There was someone in there, a patient. She was sitting in the chair, and then I pushed open the door to show her. The room was exactly as I'd left it over an hour earlier. Lights off, empty bed, cleaning supplies where I'd abandoned them. No woman in the chair, no evidence anyone had been there. Claire gave me a concerned look. "Raymond, the room's been empty all night. Mrs. Arsenault has been in dialysis since 10 p.m. I just checked. She's still down there." "But I saw her," I insisted. "She was sitting right there in that chair." She looked at me. She was real. Claire put a hand on my shoulder. "Why don't you take your break early? You've been doing this job a long time. Night shift messes with your head sometimes. Happened to me last year. Thought I saw a patient walking around who'd been discharged hours earlier. It's the exhaustion." I wanted to argue. I wanted to tell her about the bathroom door, the monitor, the breathing, everything that had happened in that room. But I could see in her expression that she thought I was having some kind of fatigue-induced episode. And maybe I was. Maybe 17 years of night shift had finally caught up with me, and my brain was misfiring. I nodded and headed to the break room. I sat there for 45 minutes, drinking terrible coffee from the machine, trying to convince myself that Claire was right. Exhaustion, stress, pattern seeking in random events. The door closed because of air pressure. The monitor malfunctioned because of an electrical issue. The breathing was pipes or ventilation. The woman was a hallucination brought on by lack of sleep and too many years of night work. At 4:15 a.m., my phone buzzed with a text from Jorge Hernandez, the other senior tech working the surgical floor that night. "Need you on 3, code cleanup in OR7. I headed down to the 3rd floor, grateful for a distraction that would get me away from the 7th floor in room 714. Jorge met me outside the surgical suite and walked me through what had happened. A routine appendectomy had gotten complicated, lots of blood, contamination protocols in effect, standard emergency cleanup procedure. We spent the next 90 minutes sanitizing OR7, work that required enough focus and attention to detail that I couldn't think about anything else. We finished around 6 a.m., and Jorge invited me to grab breakfast at the cafeteria once it opened. I was heading toward the elevators with him when I heard the overhead paging system crackle to life. "Code blue, 7th floor, room 714. Code blue, 7th floor, room 714. A code blue means cardiac arrest. It means a patient's heart has stopped. It means every available medical professional rushes to that location to try to save a life." Jorge and I looked at each other. "I thought that room was empty," he said. "Didn't you clean it last night?" We took the elevator up to the 7th floor and arrived to find organized chaos. The code team had responded. Physicians, nurses, respiratory therapists, all crowding into and around room 714. A crash cart was parked in the hallway. I could see through the open door into the room where medical staff surrounded the bed, performing chest compressions, managing equipment, calling out vital signs. Claire saw me in the hallway and approached, her face pale. "Raymond, I owe you an apology. You weren't seeing things." "What do you mean?" "Dorothy Arsenault. She came back up from dialysis early, around 3 a.m. We got her settled in 714. She seemed fine, stable, resting. Then at 5:58 a.m., her monitor started showing irregular readings, and by the time anyone got into the room, she was in full cardiac arrest. I processed this information slowly. But when I saw her at 2:30, you said she was still in dialysis." Claire frowned. "No, at 2:30, she was still in dialysis. She didn't come back up until 3. I was there when transport brought her back. You couldn't have seen her in the room before that." "But I did see her," I said. "She was sitting in the chair." She looked at me. Claire's expression shifted from confusion to something else, something that looked like recognition mixed with reluctance. "Raymond, come with me." She led me away from the commotion around room 714 to a quiet corner near the break room. She glanced around to make sure we were alone, then spoke in a low voice. "How long have you worked nights at St. Dominic?" 17 years. You know that. "And in 17 years, has anyone ever told you about room 714? I shook my head. Claire sighed. "There's a reason we don't talk about it. Because it sounds insane, and because administration doesn't want staff freaking out. But 714 has a reputation. Patients who are going to die in that room, sometimes they're seen before they die, in the room, hours before, sometimes days before." "What are you talking about?" "Sheila Martinez, one of the night nurses who retired last year, swears she saw an elderly man standing by the window in 714 while she was doing evening med rounds. She documented it, went to investigate, found the room empty. 3 hours later, that same man was admitted to 714 and died of a stroke before morning." I felt cold. "That's impossible." Tommy Nguyen works in radiology, tells a story about transporting a patient past 714 and seeing someone sitting in the bed. Reported it. Room was empty. 2 days later, the patient he'd seen, a young woman with cancer, was assigned to 714. She died there a week later. "Why are you telling me this?" Claire looked genuinely disturbed. "Because you're not the first person to see Dorothy Arsenault in that room before she was officially there. And because now you're part of something the rest of us have been dealing with quietly for years. Welcome to the club nobody wants to join." Behind us, the commotion in room 714 was winding down. The distinctive sound of a flatline alarm had stopped, replaced by quiet voices and the organized movements of medical staff who know they've lost the fight. Dorothy Arsenault had been pronounced dead. I finished my shift that morning in a state of shock, going through the motions of my final task mechanically. When I clocked out at 7:30 a.m., I drove straight home but couldn't sleep. I kept seeing Dorothy's face, that calm, knowing expression, the way she looked at me as if she understood something fundamental that I didn't. I came back for my next shift 2 nights later. I thought about calling in sick. I thought about requesting a transfer to day shift or a different facility entirely. But something stopped me. Maybe it was pride. 17 years of work, a reputation as the most reliable tech on the night crew. Maybe it was stubbornness. Maybe it was the need to prove to myself that what happened in room 714 was an isolated incident, an anomaly that could be explained away with enough time and distance. Or maybe, if I'm being honest, it was curiosity, a need to understand what I'd witnessed. I spent hours in the hospital library over the next week, going through old incident reports and maintenance logs during my breaks. What I found confirmed everything Claire had told me, and worse. Room 714 had been in continuous use since the 7th floor was added in 1984. In those 40 years, there had been 127 patient deaths in that room. That number alone wasn't unusual. Terminal patients die in hospitals. But what was unusual was the pattern I discovered in the incident reports. In 23 documented cases spread across 4 decades, staff members reported seeing patients in room 714 before those patients were officially admitted to or present in that room. Nurses, doctors, maintenance staff, even visitors, all reporting seeing a specific patient who would later be assigned to 714 and would subsequently die there. Not all the reports were clear or detailed. Many were vague. Observed figure in 714 during evening rounds, or thought I saw a patient in the room but found it empty. But several were disturbingly specific, matching exactly what I'd experienced. Staff members describing interactions with patients who weren't there yet, patients who would arrive hours or days later and die in that room. The reports spanned decades, different staff members, different administrators, different eras of the hospital. The earliest one I could find was from 1987, a nurse named Patricia LeBlanc, who wrote a detailed incident report about having a full conversation with an elderly man in room 714 about his grandchildren, only to discover the room was empty and scheduled for cleaning. The next day, that man, Theodore Washington, was admitted to 714 following a car accident. He died 3 days later. There were no explanations in the reports, no investigations, no follow-up, just documentation of impossible events that defied rational explanation, filed away and forgotten. 3 weeks after my experience with Dorothy Arsenault, I was assigned to clean room 438 on the 4th floor. Terminal cleaning after a patient discharge. Routine work. I was trying to get back to normal, trying to convince myself that 714 was a unique situation and the rest of the hospital operated according to the rules of reality I understood. I was mopping the floor in 438 when I heard it again. That slow, labored breathing coming from the empty bed. My blood went cold. I stood frozen, mop in hand, listening to that impossible sound. The breathing continued for maybe 30 seconds, then stopped. Just like in 714. I walked out of that room immediately and found the floor nurse. My voice was shaking when I asked who had been the previous occupant of 438. Albert Chen, she said. 76-year-old man, treated for pneumonia, transferred to a rehab facility this morning. I forced myself to ask the question, is there any chance he might be readmitted? She checked her computer and her expression shifted. Actually, yes. We just got a call from the rehab facility about 5 minutes ago. Mr. Chen's having complications. They're sending him back, ETA, about an hour. I thanked her and walked away on legs that felt like they might give out. Because if I could hear Albert Chen breathing in room 438 an hour before he arrived, then room 714 wasn't unique. Then this phenomenon, whatever it was, existed throughout the entire hospital. Then everything I thought I understood about the building I'd worked in for 17 years was wrong. That was 2 months ago. I'm still working at St. Dominic, still doing night shifts, still cleaning rooms and sanitizing equipment and following all the protocols I've followed for nearly 2 decades. But everything has changed. I hear things now that I used to dismiss. Footsteps in empty corridors that I would have attributed to pipes or settling building foundations. Voices from rooms I know are vacant that I would have explained away as sounds carrying from neighboring spaces. Equipment activating when it shouldn't. Doors opening and closing without cause. Shadows moving in ways that don't match any light source. I used to rationalize all of it. Now I document it. I keep a private log on my phone of every anomaly I observe, every impossible thing I witness during my shifts. The log has 63 entries so far. 63 incidents across 2 months that defy rational explanation. Other night staff have started talking to me, quietly in corners where day shift supervisors won't hear. They share their own experiences, the things they've seen and heard and witnessed that they've never reported, because who would believe them? Who wants to be the crazy person claiming the hospital is haunted? But it's not haunted, or at least not in the way people usually mean that word. It's something else. Something about places where people die regularly, where trauma and suffering concentrate, where the boundary between life and death is crossed dozens of times every day. Something about those places that makes them operate according to rules we don't understand. Claire told me last week that she's glad I'm staying. We need people who've seen it, she said. People who understand that there's more going on in this building than what's in the medical textbooks. I asked her why she stayed after everything she'd witnessed over 23 years. Because someone has to, she said. Someone has to know what's really happening here. Someone has to be aware. Even if we can't explain it or control it, the patients deserve that much. I think about that conversation a lot, about whether staying is the right choice or whether I'm just too afraid to admit that what I've experienced has fundamentally broken my understanding of reality. Last week, I was assigned to clean room 714 again. First time since Dorothy Arsenault died there. I stood outside that door for 5 full minutes before I could make myself use my key. The room was empty, just a standard hospital room waiting for its next occupant. I went through my cleaning protocols mechanically, waiting for something impossible to happen. The bathroom door stayed open. The vitals monitor remained dark. I heard no phantom breathing. Maybe that should have been reassuring. Instead, it felt worse. Because now I understand that the absence of phenomena doesn't mean anything. It just means I'm not witnessing something this time. It doesn't mean it's not happening. It doesn't mean the next person who gets assigned to room 714 won't appear in that chair hours before they're officially admitted, sitting and waiting for a death that hasn't happened yet but somehow already has. I finish my cleaning and move on to the next room. Then the next. Then the next. The same routine I've followed for 17 years, except now I'm hyper aware of every sound, every shadow, every small deviation from normal that I used to ignore. I clock out at 7:30 a.m., drive home, try to sleep during the day. I come back at 10:45 p.m. and do it all again. I don't know how long I can sustain this. Working every night in a building where the fundamental rules of cause and effect don't consistently apply, where patients can exist before they arrive, where death announces itself in ways that violate everything we understand about time and space. But I also don't know how to leave. Because if I walk away, who's going to document what happens in room 714? Who's going to keep track of the patterns, the incidents, the evidence that something impossible is occurring regularly in this hospital? Who's going to be the witness? What disturbs me most now isn't what I saw in room 714. It's the realization of how much I missed during my first 17 years working at St. Dominic. How many anomalies I rationalized away because they didn't fit my framework for understanding how hospitals work. How many times I walked past something impossible and dismissed it as equipment malfunction or exhaustion or my imagination. I think about all the other hospital workers out there. Thousands of people working night shifts in medical facilities across the country. How many of them are experiencing similar phenomena and dismissing it? How many of them are seeing patients who aren't there yet, hearing sounds from empty rooms, watching equipment behave in ways that violate its programming? How many of them are like I was 2 months ago, so committed to their rational understanding of reality that they can't allow themselves to acknowledge what they're actually witnessing? I've tried researching this, looking for academic papers or documented studies about temporal anomalies in medical facilities, about places where death occurs regularly, and whether that creates some kind of observable effect on the physical environment. I've found nothing credible. Lots of ghost stories and paranormal speculation, but nothing that approaches this from a serious investigative perspective. Maybe that's because anyone who tries to study it seriously gets dismissed as a crank. Maybe it's because the phenomena are too inconsistent, too unpredictable to investigate using standard scientific methods. Or maybe it's because the people who work in hospitals and witness these things have too much to lose: career, credibility, professional reputation, to ever report what they're actually experiencing. So we stay quiet. We keep working. We document privately but never officially. We warn each other in hushed conversations during night shifts, but never put anything in writing that administration might see. And the building keeps operating according to its own rules, independent of our understanding or acknowledgement. I just checked my schedule for next week. I'm assigned to floors 6 through 8 again, which means I'll be responsible for room 714 if it needs cleaning. Part of me hopes it stays occupied all week. Part of me dreads the moment I have to use my master key and walk into that space again. But I'll do it, because this is my job. Because I'm good at what I do, even if what I do now includes bearing witness to things that shouldn't be possible. Because someone has to clean room 714, and someone has to know what really happens there. I'm Raymond Kellerman. I'm a senior environmental services technician at St. Dominic Medical Center in Baton Rouge, Louisiana. I've worked here for 17 years, and I'll probably work here for 17 more. But I'll never look at this building the same way again. I'll never trust that what I'm seeing is all that's actually happening. I'll never assume that the rules I learned about hospital operations are complete or accurate. And every time I walk past room 714, I'll wonder who I'll see sitting in that chair next. And I'll wonder if they know, the way Dorothy Arsenault seemed to know, that they're already in the place where they're going to die, even if they haven't been admitted there yet. Even if, according to every rule we understand about how time works, they're not supposed to be there at all.